o'clock. We'll get started. I'm delighted to be here on this sunny and cold day. We have a special tag team presentation today. And to do the introductions, Dr. Jarjour.
Good morning and thanks, Lynn. Good morning to all of you. It's my great pleasure and honor to introduce today's speaker. First, Dr. Phil Farrell. Dr. Farrell earned his MD and PhD degree in 1970 from St. Louis University while being supported on the original version on the NIH MSTP grant. During his training in biochemistry and nutritional sciences, Phil developed an early interest in genetics and pulmonary surfactant metabolism. Next, he moved to Madison, to UW, for a residency in pediatrics, followed by a fellowship, in addition to 3 more years of research at the NIH. Returning to Madison in 1977 as a neonatologist and pulmonologist, he obtained his first of several R01s and then 2 SCORE grants as he established a research career that has benefited from 50 consecutive years of continuous NIH funding. This support has led to more than 300 papers on topics that are very important in the evolution of pediatric pulmonary field. While maintaining an R01 grant support and studying cystic fibrosis through clinical trials on newborn screening, Dr. Farrell served at the same time as a chair of pediatrics from 1985 to 1995, and then as our School of Medicine dean until 2006. After that, his research has intensified and is now featuring the application of whole genome sequencing in cystic fibrosis research and treatment. Since 2006, he has also served as a CF Foundation National Facilitator on newborn screening and quality improvement throughout the US as an advisor to several other countries. I'm going to mention a couple of Phil's honors. There are many. First, in 1995, he was the Wisconsin Pediatrician of the Year, designated by the Wisconsin chapter of the American Academy of Pediatrics. In 2005, he was the Distinguished Scientific Achievement Awardee by the CF Foundation. 2012, the CDC awarded him for excellence in leadership of newborn screening and quality improvement. In 2019, he received an honorary doctoral degree in genetics from Université Bretagne Occidentale in Brest, France. And 2020, he received the Founders Award from the American Thoracic Society Assembly on Pediatrics. As a medical school dean, Phil supported my recruitment as a division head for pulmonary in 2004, and forever I will be very grateful to that support, Phil. He was also very instrumental in recruiting our second speaker this morning, Dr. Andrew Braun. Dr. Braun is a native Wisconsin and attended the University of Wisconsin for his undergrad and medical school training. He began his CF research first as a medical student with Dr. Farrell as his mentor, completed an internal medicine residency at the UCSF and a fellowship in pulmonary, critical care, and sleep medicine at the Johns Hopkins University in Baltimore, where he continued as a junior faculty until we were very fortunate to recruit him and lure him back to Wisconsin in 2017 as an assistant professor in our division. Dr. Braun is the director of our UW-CF program for the adult side, and he is the co-director of our CF Therapeutic Development Network. In that capacity, he is the PI for 9 active clinical trials in cystic fibrosis. He has also additional role as a physician dyad for D65, medical director of our inpatient advanced pulmonary service, and our outpatient physician in pulmonary as well as in Wisconsin sleep. During the COVID-19 pandemic and surge, Andrew has played a very important and commendable leadership role in planning our pulmonary and critical care response and coordinating with other teams, especially our colleagues in hospital medicine. For his outstanding effort in that regard, he was awarded the DOM Chair's Commendation, receiving one of the inaugural Golden Bucky Awards that he proudly holds back here in his office, and you can probably see it in one of his shelves. Today, Phil and Andrew will speak to us on cystic fibrosis, 5 decades of science, advocacy, and discovery, from public health to genetics to the potential for cure. Please welcome me, join me in welcoming Dr. Farrell and Braun to this virtual podium. Phil, I understand you will start.
Yes. Well, thank you very much, Nizar, for that kind introduction and for this opportunity and privilege. And thanks also for this insightful title for the lecture today. Andrew and I have no current conflicts of interest to disclose. And our plan today is very simply to divide this topic into two components. First, I'm going to focus on diagnosis through newborn screening using genetics. And then Andrew will concentrate on the exciting recent data on molecular therapeutics, particularly the opportunity that we all enjoy to use CFTR modulators towards what's truly going to eventually be a cure of cystic fibrosis. Our learning objectives are very straightforward. I'm going to describe Wisconsin's role in the history and the use of CF newborn screening with the IRT DNA test we developed on the Madison campus. That is the test that uses as a first-tier measurement of immunoreactive trypsinogen. And when that level is high, a follow-up DNA extraction and evaluation of CFTR mutations. This is a very good test, but there are false negatives results, especially in minority populations, that you should be aware of. We're going to help you appreciate the 6 CFTR mutation classes that we can now identify through newborn screening, and we use them for developing care plans, particularly selection of CFTR modulators. Andrew will describe the impact and the mechanisms of these modulators and how this applies for personalized precision medicine. Before I begin, I want to make a few comments about Department of Medicine leaders and thank these 5 leaders of the medicine department. Although I never had an opportunity to work with Dr. Middleton, he left me a playbook that proved invaluable. There was a playbook for deaning that proved invaluable when I became dean and led to my relationship with Andrew Braun. And I've always been grateful for having that playbook available to me in the dean's office. I did work with Helen Dickey briefly, but I consider her a mentor because Helen encouraged and supported my interest in developing a pediatric pulmonology program here in Madison at a time when the leaders in pediatrics were very skeptical and doubted that there would ever be such a discipline. Helen kept encouraging me to hang in there. Helen, of course, was famous for her perseverance and her toughness, and I really benefited from that brief relationship. Jeff Grossman, I hope that you're zoomed in today because I can't thank you enough. You're simply the best. And in my judgment, the MVP of the school during our 2 decades of incredible transformations. Bill Bussey deserves my thanks because he's always been my role model. And I really have always appreciated working with Bill. And last but not least, Nizar, whose name rhymes with superstar for a good reason, for many good reasons. And I'm very grateful to Nizar, both personally and professionally. Just a final introductory comment. This is the 20th year that Andrew and I have known each other. We met during his first semester of medical school. We planned this project and published an important paper together on genotype-phenotype relationships, showing that some classes of CFTR mutations, as they would become known, lead to a later onset and a milder course of lung disease. And at that time, Andrew and I both realized that we were fascinated by the challenges of cystic fibrosis. One of the reasons we're we're fascinated by the challenges is this is a very complex disease that was mysterious for decades as to its underlying etiology. As you know, it's an autosomal recessive disorder. Its incidence is relatively high among genetic disorders. It is the most common life-threatening genetic disorder of Caucasians, with an incidence of about 1 in 3,000 white Americans, 1 in 6,000 among Hispanic Americans, and at least 1 in 10,000 among African Americans. It has traditionally been thought of as a disease of white people. However, this is a misconception because during the last 10 years of newborn screening, 20% of the patients diagnosed through newborn screening are minorities, and particularly Hispanic Americans and African Americans. And so we no longer should be thinking of this as a white person's disease. The earliest manifestations of CF are gastrointestinal, particularly the pancreas, and pancreatic pathology is present in utero by 20 weeks of gestation or earlier after birth. This leads to pancreatic insufficiency in 85% of patients with CF, but the other 15% do not have a normal pancreas either. And so this lesion is a very, very common feature and significant problem for CF patients. Leads to intestinal malabsorption, particularly fat and protein, and fat-soluble vitamins, and will cause severe malnutrition. Moving over to the left, salt loss and sweat is a characteristic feature, as unusual as that might seem, but this also forms a diagnostic test and is a clinical risk to patients, particularly children who are sweating, infants who are breastfed with its low sodium chloride content. This can be a fatal problem for children and adults with cystic fibrosis. And then finally at the top, because of its great importance in determining the fate of each patient, lung disease. Now it's interesting that the CF lung is normal, appears normal at birth, but within weeks, chronic infection will supervene with inflammation and eventually airways obstruction, and eventually all patients will have lung disease. And we now know that as early as 10 weeks of age, irreversible lung disease can develop, namely bronchiectasis. Now, there are many other clinical manifestations shown at the bottom of the slide. So this is a disorder with numerous kinds of abnormalities, signs, symptoms, et cetera. So you would think this would be very easy to diagnose. That's not the case at all. It is a difficult disease to diagnose, and that troubled me throughout my career, particularly in the 1970s, because I learned in medical school that every physician's first duty is to diagnose accurately and promptly. After all, diagnosis is the first step of treatment, but some diseases cannot be diagnosed before irreversible progression occurs. Cystic fibrosis is one of them. In fact, 5 to 10% of CF patients used to die undiagnosed prior to the implementation of newborn screening. So in those cases where the disease can't be diagnosed before irreversible progression occurs, screening programs are very desirable, and they've been developed with a goal of achieving more good than harm, because every screening program that exists can create harm, cause harm without a doubt. In pediatrics, the most prominent aspect of screening, the most prominent programs are involve newborns screening for genetic diseases like phenylketonuria, the prototype genetic disorder, and cystic fibrosis. In medicine, of course, cancer screening seems to predominate. I want to remind you that screening refers to the application of a test to people who are as yet asymptomatic for the purpose of classifying them with respect to their likelihood of having a particular disease. In other words, identifying their risk. But the screening procedure itself does not diagnose illness in the traditional sense of screening. Those who test positive then must be sent for further evaluation by a subsequent diagnostic test or procedure to determine whether they do in fact have the disease. Now, this is changing with the application of molecular genetics screening tests. And in fact, this is changing in cystic fibrosis, as I'll explain to you. And in fact, the CF newborn screening test we use now has basically transformed a screening test into a diagnostic test, as you'll see shortly. Because of nationwide advocacy efforts by parents and physicians, public health programs have implemented screening of newborn babies for genetic diseases as one of our largest population, one of our earliest and largest population-based screening programs, generally operated out of public health departments, and applying preventive medicine in defined regions like states to reduce infant morbidity and mortality from biochemical genetic disorders, with pre-symptomatic detection linked to diagnosis using dried blood spot specimens, I'll show you. And these specimens are analyzed in central laboratories with linkage to clinical follow-up centers like CF centers that Andrew will show you. And this, this whole program for newborn screening absolutely depends on having a cost-effective and reliable test, which is the big challenge. The newborn screening begins with collection of very small specimen of blood. All of you participants who were born after the mid-60s had newborn screening performed, and certainly all of your children have had newborn screening performed these days for about 50 genetic disorders. The blood specimen that's collected on filter paper called a Guthrie card is a very small specimen, about a total of 0.4 ml of blood that's dried on this card before it's punched out for analyses. But that those specimens contain about 5 to 10 micrograms of DNA, and this allows numerous tests, molecular tests, to be performed. And in fact, we use this blood for sequencing the CFTR gene routinely on the Madison campus, and we can even perform whole genome sequencing on this very small specimen of blood. So when you take that into account, whole genome sequencing on this specimen, it'll give you an idea where newborn screening is going in the future. Even though I don't have a crystal ball, I can see whole genome sequencing being performed on every baby born in the United States, and maybe even before that, born in the UK. The principle of achieving better outcomes through newborn screening is shown on this slide. If a disease has a preclinical stage, and there is a good, reliable, effective screening test linked to a follow-up program for confirming a diagnosis plus effective therapy, there's very good rationale for early diagnosis through newborn screening. One of the challenges is the preclinical stage can be very short. For example, in CF, malnutrition can develop within a matter of days. Babies can die within a matter of a week from hyponatremic dehydration or severe protein energy malnutrition within a few weeks. And as I said, lung disease develops with bronchiectasis by as early as 10 weeks of age. And so newborn screening has to be expedited soon after birth. Now, we didn't have a good test, a good enough test, let me put it that way, good enough test for CF newborn screening until after discovery of the cystic fibrosis transmembrane conductance regulator gene, the CFTR gene, in 1989. This gene was discovered as a major breakthrough in the history of CF research. And the principal pathogenic variant, known at that time as Delta F508, was also described in the 3 articles published in this issue of Science. This mutation is now more commonly referred to as F508del. Codon 508 is altered by 3 base pair deletion that leads to loss of a phenylalanine residue at a very important part in the molecule, a nucleotide binding domain. Well, this discovery explained the mysterious pathophysiology of CF, because CF is caused by a chloride channel defect. The discovery of the gene allowed the prediction of the proteins, primary and secondary and tertiary structures. And I'll show you that in just a few minutes. But that explains the mysterious pathophysiology of CF. On a more practical level, it enabled newborn screening to occur by the IRT DNA test that I've already mentioned to you. Now, I want to say a word about the cover of this magazine. Andrew would tell you more about the CF patient that's sitting there. The designer of this cover, Batsheva Karim, told me that the red lines represent the F508del mutation. But the team, shown in the lower right corner of the slide, that discovered CFTR gene and F508del had good reasons to believe that there would be other pathogenic variants discovered. And so they put in that orange component, and then a yellow, and then a green, a blue, et cetera, with an estimate that there would be about 6 more pathogenic variants discovered. This turned out to be totally wrong. Over 2,000 mutations have been discovered in the CFTR gene, and about 20% of these we know now will cause CF or pathogenic. This slide lists some of the more frequent pathogenic variants in the roughly 30,000 patients of the CF Foundation patient registry. This is the top 25, but you'll see after F508del, which occurs in 85.8% of US patients, the frequencies drop off very quickly. And by the time you get down to number 13, there's only 1% frequency. However, each one of these variants is very interesting. And if we were geneticists, I think we'd spend the rest of the hour discussing all these mutations, but we're not geneticists. And this would bore you at some point in time. So I'll just comment on a few of these pathogenic variants. The F508del, of course, is the most interesting. It occurs on exon 10, a nucleotide binding domain. This is a very old mutation. Our research shows that it arose about 5,000 years ago in the Bronze Age, and it accounts for the high incidence of the disease. 1 in 25 Western Europeans have a F508del mutation. They are CF heterozygote carriers. With the population enriched to that extent, there's obviously a selective advantage for CF carriers, but that has not yet been discovered despite research underway by our group and others for many years. The second on the list there, G542X, is called the Phoenician mutation because it's found around the Mediterranean shores. It's a mutation with a premature termination codon, very difficult to treat. The next one is G551D, and this is called Celtic mutation because it occurs in Ireland, the UK, Brittany, other countries where the Celts settled for hundreds, if not thousands of years. Just one other comment, you'll notice towards the bottom of that list, many splice site mutations. These mutations are occurring in introns as well as exons, and These splice site mutations account for close to 20% of all the pathogenic variants. And when you add them all up, and so this is a very important area of research that Andrew will tell you about. Just a few words about the gene. It's a relatively large gene, 27 exons, 26 introns, about 189,000 nucleotides in the gene. Plenty of opportunities for mutations in both the exons and to a lesser extent in the introns. After removal of the introns and this complex splicing mechanism across the messenger RNA, we wind up with 4,400 nucleotides and a protein that's 1,480 amino acids that has a membrane spanning component that is the ion channel. And then you can see on this slide the nucleotide binding folds are domains. But because it's a relatively large gene that's been around for at least 5,000 years with mutations, it's not a surprise that we'd have a couple of thousand mutations in the CFTR gene. Now, I want to finish up with some comments about newborn screening tests. Using dried blood spot specimens, screening became possible in 1979 when it was shown that immunoreactive trypsinogen was high in the blood of babies with cystic fibrosis because of obstructed pancreatic ductules and leakage of this zymogen into the bloodstream. This test was good, but not good enough. And after discovery of the CFTR gene, we immediately on the Madison campus began to develop the two-tiered test, IRT DNA, using the F508del mutation only at that point in time to detect close to 90% of the babies with cystic fibrosis. We made a change to a 23 mutation method in 2003. And this definitely improved our sensitivity with no sacrifice in specificity. Now we're at the point where we use next generation sequencing. When the IRT level is high, we sequence the CFTR gene and the software reports to us 365 pathogenic variants, mutations that are known to cause CF. This is a major advance because it allows us to detect 2 pathogenic variants in the dried blood spot specimen that effectively establishes the genetic diagnosis of CF. That is a presumptive diagnosis of CF, although we still do a sweat chloride test to confirm this. But this is what the newborn screening has progressed towards now. It's a major change as the evolution has proceeded along the lines of new genetic biotechnologies. Even though the early diagnosis through newborn screening seems quite desirable, there were many skeptics in the 70s and 80s about its value. And so we proposed a randomized clinical trial in a state that's ideal for this kind of a study. We obtained IRB approval in 1983 for the protocol, and we obtained funding in 1984. I should mention to you that this protocol approved in 1983 is still an active project. It's been approved by the Human Subjects IRB for 38 straight years. And that's because we're still evaluating the patients with whole genome sequencing. Same cohort is still under investigation. This is sort of a mini Framingham study. We randomized the patients in 1985 to 94, accrued them through a unblinding method that allowed us to detect all of the patients randomized to the traditional diagnosis or control group. And as I say, we've continued with the evaluations. It was the largest randomization since the 1957 polio vaccine field trials. We randomized 650,341 babies throughout Wisconsin, and we wound up with a a very interesting early diagnosis group compared to the control or traditional diagnosis group. Make a long story short, this study showed that the benefits outweighed the risks. There was more harm more good than harm achieved. And the benefits are nutritional, pulmonary, and psychosocial. Even when we published our first paper demonstrating benefits in the New England Journal of Medicine in 1997, there were still skeptics. And so we made this relatively strong statement that the burden of proof is on those who argue against neonatal screening for CF. Pretty soon, no one wanted to argue against it. And the CDC stepped in, and the CDC reviewed all of the evidence for benefits and for risks, and in an unprecedented role for the CDC, only time they've ever weighed in on a newborn screening test, they recommended universal CF newborn screening. And they selected as the cover this very interesting trio of babies, a parent white baby in the middle, a parent Hispanic baby on the left, and an African-American on the right, with the understanding that we would now have an equitable method, an egalitarian method for early diagnosis. But despite that expectation, we haven't achieved this because the CFTR mutations of minority groups are different than what we find in the white population. And that's why the state of Wisconsin has gone to CFTR sequencing and a 365 mutation method. And this is a major area of research now to achieve DEI goals. So we truly will have an equitable screening test at some point in time. I like to call this the globalization of the Wisconsin idea. This slide shows where the IRT DNA test developed on the Madison campus is being used now around the world for early diagnosis of patients, of babies with cystic fibrosis. We're up to about 12 million babies being screened now internationally, and this is changing the face of cystic fibrosis. Because it's a DNA test, we're able to not only establish a diagnosis, but we can genotype the patients, and we can place their genetic mutations into classes that allow us to plan for care, and particularly for molecular therapies that Dr. Braun will now discuss.
Good morning, and thank you for the opportunity to speak today. And before you, I have a slide that Dr. Farrell just finished with, and this is a complex slide, and I do want to speak through this in the next couple of slides here. But first, I want to show you really what is the modern face of CF today. And in the last decade, we've had some paradigm shifting therapies that have become approved, which are changing the future for CF. So this is the modern face of CF today. That 4-year-old boy, Danny, who was on the cover of Science magazine in 1989, is now a 36-year-old adult. And there's many reasons in the last 50 years that we have been able to reach this state of health in our CF population. Here I show pie charts from 1990, 2000, 2010, and 2020 of the median FEV1 at 18 years old. And in green, we see the percentage of patients at 18 years old who had normal lung function, gray mild lung disease, yellow moderate lung disease, and red severe lung disease. And you can see in the last 3 decades, we've had dramatic improvement in lung health such that by 2020, a majority of children reach adulthood with normal lung function or just mildly reduced lung function. Much of this is related to early diagnosis due to the newborn screening processes that Phil spoke about earlier. And such that now adults now outnumber children with CF. So here we see from 1990 to 2020, the number of individuals living with CF, in green, the number who are children, and blue, those who are adults. In 1990, we had 18,000 individuals living with CF, 68% of whom were children. And now in 2020, there are 32,000 individuals in the United States with CF, 58% of which are adults. By 2030, yes?
Sorry to interrupt, but could you reduce your Zoom bar at the top? It's hiding the title of your slide. Should be a little button that allows you to bring it up. Sorry to interrupt.
Sorry, I'm not sure how to do that. Can you say again how to do that, Clint?
There should be a little arrow that allows you to pop it up, hide it, minimize it.
Is that better?
It's actually down on the bottom now, so it's hiding half of your lower half of your screen. If you have a second monitor, you can pull it off on the side or something.
Unfortunately, I don't. And I have to keep going, I think, as is. Sorry about that. So by 2030, we predict there to be 42,000 individuals living with CF, 30,000 of which are adults. In the state of Wisconsin, there are approximately 700 people living with CF today. So in those last 70 years, we've had incremental improvement in survival. Here we can see the improvement in survival over time. And by 2010, we had achieved a median predicted survival for patients born with CF of 40 years. This was related to improvements in pancreatic enzyme therapies, airway clearance, antibiotics targeting, for example, Pseudomonas infection, which is the primary organism that affects CF lungs. And in the last 20 years, from the 1990s to 2000s, the implementation of many different inhaled therapies that started to decrease the decline in lung function. So coming back to this slide, on the left, we show the central dogma of molecular biology, where DNA is transcribed into RNA and translated into a protein that functions. In CFTR, that DNA is translated into a protein that functions as a chloride ion channel at the cell surface. To be able to direct therapies towards this CFTR protein, we needed to understand what type of protein defect that mutation led to. So we have developed a classification scheme to describe that. Our class 1 mutations are mutations that lead to no protein synthesis. Essentially, nonsense mutations occur that stop further processing of RNA into protein. In class 2 mutations, of which the F508 delta mutation is the primary form, a CFTR protein begins to be synthesized, but due to misfolding of that protein, it gets targeted by the cell machinery for destruction. So again, protein never reaches the cell surface. Fortunately, in the class 3 through class 6 mutations, we have protein that reaches the cell surface. And so when we started looking at the development of CFTR protein-based therapies, those were the first classes of mutation that were targeted. I'm going to speak in more detail of those new therapies that we call CFTR modulators. But first, I want to show a short video that was developed by the Cystic Fibrosis Foundation to show you how CFTR works within the lung. Here we see ciliated airway epithelium. The cilia cells are bathed within an airway surface liquid layer, and on top of that liquid layer lies mucus. The normal functioning ciliated airway cells need that airway surface liquid layer to allow for appropriate movement. And here is the CFTR chloride channel. There's chloride ions exiting the cell, but when that becomes disease, those yellow chloride ions cannot get out, which leads to dehydration of that airway surface liquid layer. That dehydration affects ciliary functioning, increases mucus, and eventually infection and inflammation leads to bronchiectasis and the progression and decline of lung health. So moving on to the classification that would help us to develop CFTR modulators, we first started by assessing those with class 3 mutations. On the left, what happens in class 3 mutations is that we have a protein that is able to target to the cell surface, but there's a problem with the gating mechanism. The G551D mutation, which is that Celtic mutation that Dr. Farrell spoke about earlier, affects approximately 4% of individuals with CF. So these individuals have a protein at the cell surface, and if we can develop therapies to improve that gating mechanism, we'd be able to potentially improve chloride conductance. So drug development started with high throughput screening of molecules and cell-based assays of these G551D protein products. And we were able to develop oral therapies initially tested in animal studies that then moved into clinical trials nationwide. At the same time that those therapies were being developed, there was a nationwide effort to ensure genotyping for all patients with CF. And once someone is diagnosed with CF, there's free gene sequencing available such that we know their mutations. Additionally, a national multi-center development network was set up. We are one of 89 centers participating in the Therapeutic Development Network that has led to these CFTR modulator developments. So in 2012, the first-in-class CFTR modulator was approved. This is an oral therapy, and essentially what it does is connect to the gating mechanism of the protein, leading to a conformational change to increase chloride conductance through that chloride ion channel. We call this a potentiator. And in the phase 3 randomized clinical trial, of which 150 people with a G551D mutation participated, we saw a dramatic reduction in the pulmonary exacerbation rate, a reduction in respiratory symptom scores that was really underlined by dramatic improvements in the biochemical function of CFTR, leading to an improvement in lung function. I show that data here. So here we see sweat chloride values in patients that were in the placebo arm in gray and the treatment arm in blue. Over a 48-week period, we saw a dramatic reduction in the sweat chloride values of patients in the treatment arm. So much so that the sweat chloride value fell below our diagnostic threshold for CF of 60 millimoles per liter. At the same time, we saw a dramatic improvement in lung function, such that within 2 weeks, patients on average had an improvement in their FEV1 by 8 to 10%. All other therapies that we have approved in the last 2.5 decades for CF typically set a bar of 3% improvement in lung function. So to see an oral therapy that is improving the underlying protein defect in CF and leading to a tripling in what we consider the minimal clinical difference for lung function was dramatic. Patients who started on this therapy in 2012 saw additional health benefits. There was a significant decrease in exacerbations over time. By looking at the CF patient registry data from 2011 prior to the availability of ivacaftor, and subsequently 5 years afterwards, we saw a reduction in the ivacaftor group, who is in the light gray bars, by essentially 10 to 15% in their exacerbation rate, while the comparator group of patients ineligible for ivacaftor actually had an increase in exacerbations over time. Additionally, we started seeing a signal that those who had effective CFTR modulation were actually beginning to clear some of their infection. The improvement in airway clearance led to a decrease in the percentage of patients colonized with Pseudomonas. But the problem with this is that that G551D mutation is only present in 4% of individuals. And so a minority of our population was able to benefit from this new therapy. To really make a significant mark, we were going to need to target patients in that class 2 mutation, of which the delta F508 predominates. In this group of patients, the protein is misfolded such that it's unable to target to the cell surface. And so it's a much bigger barrier on how to find therapy targeted towards them. We needed to develop molecules that could aid in that protein folding process, and we call those therapies correctors. So in 2015, The second generation of CFTR modulator was approved for use. Lumacaftor aids in protein folding, and it chaperones that CFTR protein to the cell surface. We call this a corrector, and the combination therapy of a corrector and a potentiator was initially available for patients with 2 copies of a delta F508 mutation. I'm going to show you the data on our next slide. This therapy, when approved, did have significant benefit, but did have a moderate adverse event profile that led to a 3rd generation modulator that became available in 2018 with less side effects, known as tezacaftor. So in that original Lumacaftor trial, here we show that 96-week data of improvement in lung function. In the green is the placebo arm, and in the blue is the Lumacaftor ivacaftor arm. As you can see, the FEV1 improved by approximately 3%, close to that bar that we have set for other respiratory therapies with CF, but nowhere near the 10% improvement we saw in lung function in patients with that G551D mutation, where we already had protein at the cell surface. So this was a good first step. We were able to show potentially some stability in a larger population of CF patients, but to really have a significant improvement, we were going to need additional correctors to force that protein to the cell surface. So here on the right, we see the CFTR protein, and what was discovered in that time frame was that there are actually 2 key sites within the protein that help to improve the protein folding to achieve cell surface presentation of the protein. And in 2019, Elexacaftor, tezacaftor, and ivacaftor in combination was approved for use. And here we saw the dramatic effect that we had seen in that G551D population, essentially mirroring the data from 2012. So there was a dramatic drop in sweat chloride concentration in patients on the triple combination therapy. And we also saw an improvement in the FEV1 over 24 weeks of 13%. Even more than we had seen in the G551D trials. We also saw a dramatic improvement in hospitalization rate, pulmonary exacerbation rate, and use of IV antibiotic therapy. And this therapy was approved for patients with just 1 copy of the delta F508 mutation. So opened up modulator therapy to approximately 90% of people living with CF. I want to share with you our case example here at UW of our first patient to start on commercial product of Elexacaftor, tezacaftor, ivacaftor. This is a 28-year-old gentleman who had 2 copies of the delta F508 mutation, had been on the prior generation of CFTR modulators, and he had nadired his FEV1 to 19%. He'd had recurrent hospitalizations and was in evaluation for lung transplant. We were able to get access to the new triple combination therapy by early access programs. And in a 3-month period, this patient's FEV1 improved by 25%, moving from 19 to 44% predicted. He had increase in weight as his degree of pulmonary cachexia improved, and he was removed from lung transplant consideration. This case is mirrored nationwide. So here is the data prior to triple combination therapy availability in 2019, looking at birth cohorts from 1990 to 1994 in 5-year increments. Over time, lung function decline is the primary progression that we see in patients with CF as they age. And this data in 2020 has already begun to show a bending of the curve, where implementation of highly effective modulator therapy is showing improvement in all age cohorts that are eligible for this drug. Additionally, we've seen significant improvement in rate of hospitalizations, pulmonary exacerbation rates, and need for IV antibiotic therapy. Here we see data from 2006 to 2020. The blue line are adult patients who are requiring antibiotic therapy, and approximately 40 to 45% of our patients would need to be hospitalized for IV antibiotic therapy per year. In 2020, there was a dramatic decline to only 18% of patients requiring IV antibiotics. We've also seen a significant reduction in the need for lung transplantation. Historically, in the last 5 years, we had been seeing anywhere between 200 and 250 lung transplants per year. You can see that over time from 1993 to 2020, there have been an increasing need for CF lung transplantations. In 2020, we saw a decline to only 91 lung transplants, a 70% decrease. In 2021, we are reaching the end of this year, and reportedly there will be less than 50 CF lung transplants in 2021. Additionally, we have seen what we're calling the CF baby boom. So CFTR is present within the cervix, and cervical mucus is thickened, making it often difficult for women with CF to become pregnant. So not only has initiation of highly effective CFTR modulators led to an increase in the number of pregnancies we're seeing, the viewpoints of women is changing in their life expectancy, in their quality of life, and their ability to consider having pregnancies. Our survival statistics continue to improve. Here I show the increasing survival from 1989 up until the year 2000. We look at this in 5-year increments for the smoothing effect that provides. For a child born today, we currently expect a life expectancy of up to 50 years, but presume we will see continued improvements in the coming years. What most of our patients care about is conditional survival. So what they want to know is, hey, I've reached this specific age. How long do you expect me to live from now? Historically, for example, our 30-year-old patients, when they were born, they were told that they might not expect to live until they were 30. So now we have adults living to 30, and we're able to tell them that the median expectation for life is into their 50s or 60s. So these new therapies are dramatically altering the vision of the future for our adults living with CF. We have also seen a dramatic fall in the death rate in the last year, with falling below 1 death per 100 individuals for the first time. So what's next? We now have effective CFTR modulator therapies that can repair the underlying protein defect. The bubbles here on the left show how many people are eligible and eligible for which of our CFTR modulators that are currently present. But you can see that there are bubbles that still have patients that don't yet have therapy available for them. Either they're ineligible due to age, they have non-responding genotypes, or they have missing or unknown genotypes that make it difficult for us to develop therapies for them. Ideally, we can find therapies that are gene agnostic. And so the next phase of CF research and therapeutics will be looking into restoring the CFTR protein when no protein product is being made, such as in those class 1 mutations, or fixing or editing the gene directly. And so I just want to give you a quick snapshot of what that looks like. So here, the class 1 mutations on the left, we see that there is no protein product that is formed. So a CFTR modulator is not going to work as we cannot chaperone a protein to the cell surface. So these patients need to benefit from therapies that can add in additional, sorry, I'm going to move this here, that can essentially gene edit. So here I'm showing in vitro data from a lab just published here in the last year that is able to insert what we call a super exon into the CFTR gene. The delta F508 mutation occurs in the 10th and 11th exon, and this group is able to reliably insert what we call a super exon of the CFTR exons 9 through 27 in a position after exon 8. So in many different types of mutations, including delta F508 or the G542X or Phoenician genotype that Dr. Farrell described, this type of therapy, if able to move into the in vivo environment, can be beneficial. Additionally, splice mutations, which are class 5 mutations, there is CFTR protein that is synthesized, but unable to produce enough quantity to move CFTR to the cell surface for it to appropriately function. And there are now therapies that are being developed that can improve these splicing mutations as well. So hopefully I've been able to show you how understanding the underlying genetics of CF has led us to be able to develop therapies that affect the underlying protein product, and that the modern face of CF is changing. And we expect this to continue to improve into the future. I'd like to thank the multidisciplinary team that I work with here at UW, and I look forward to any questions.
Great. Great, thank you. Really wonderful talk and an amazing story. I think many of us have been blessed to see the progression over the past 25 years from prior to cloning of the gene to now molecularly based therapeutics. It is pretty remarkable. So there's a question from Jen Weiss, wanting to know your thoughts on the mechanism for increased risk of colorectal cancer in patients with CF, whether or not they have a transplant. Any thoughts?
I'd like to take a crack at that one, if I might, Len. And I apologize to the gastroenterologists and hepatologists who are participating this morning, because we could spend the whole hour on GI aspects of CF, but we're pulmonologists, Andrew and I, so we stayed focused on the respiratory system. But I think this is a great question. I've been very interested in this issue of increased risk of colorectal cancer for CF patients. At one time, it was thought they might be resistant to cancer, and this might be the selective advantage of the CF heterozygote carrier. However, there are enough articles now that indicate an increased risk of colorectal cancer that I think we have to accept this as established. There are a couple papers that don't agree with it, but I think it's established. So regarding the mechanism, I think it's a great area for future multi-center research. I can't explain it, but I'll speculate. And one of the hypotheses that could be tested is that the GI microbiota are responsible for this. The population of microbes in the colon. Now, we have unequivocal data from a study of children ages 1 to 6 years of age that shows that without any doubt, they have a markedly altered microbial population based on our studies of feces from these children. The changes that we're finding are so striking that we're just beginning to realize what kind of clinical significance there might be. But I've wondered about that risk for colorectal cancer. That is a possibility. Another possibility is the somewhat frequent occurrence of distal intestinal obstruction syndrome and less florid presentations of that. The GI tract of CF patients, their stool patterns are really quite variable. And as I say, I think this is a great area for future research.
And I would note that we do screen patients with CF early for colon cancer. So that colonoscopy screening starts at age 40. And there's an upcoming study that will be also looking at a molecular-based stool tests as well for early screening of colon cancer in the CF population.
So the short answer is we don't know, but we're screening for it. Would that be correct?
Yes, Lynn, and I'd like to add an optimistic viewpoint. We'll find out.
Good. Yes. Excellent. So I have a couple of questions. One is, there are other ion channels in the lung and like ENaC, et cetera. Is there evidence for mutations in other channels that may contribute to a CF-like presentation?
That is a fantastic question. Phil, of course, feel free to answer as well. So, ENaC, its gene mutation profile is still understudied, and we have so many patients that come to us with altered sweat chlorides that may also be affected by the ENaC as well. And so I'm often seeing patients with bronchiectasis and maybe a sweat chloride in this intermediate range of 20 to 30 to 40, and unable to really find a clear answer of why that is. And I wouldn't be surprised if ENaC mutations or other mutations of chloride channels within the lung are affecting that airway surface liquid layer and the disease that develops.
Great. And then you alluded to the increasing pregnancies in patients with CF, et cetera. What, for both the screening and in adult populations, what genetic counseling do you provide patients, and your thoughts on that?
So we talk with all of our women who are considering pregnancy and talk to us about that beforehand to consider meeting with a genetic counselor. It's very interesting because in this era of highly effective modulators, there have actually started to be reports of CF patients that become pregnant and have children that have normal newborn screening tests, but actually they were in utero being exposed to Trikafta, and they actually had a partner who was a CF carrier. And so it is really changing how we recommend patients to have genetic screening beforehand. So now for any patient that is on a modulator, we highly recommend that their partner be screened so that they know at birth, if a newborn screening test is done, it may be false. And we now have to recommend that if the partner's genotype is unknown, that those babies should have sweat chloride testing and potentially even have gene testing within 3 months after birth to ensure that they don't have CF.
Are there any complications of the pregnancy per se that does it put them at a high risk of a pregnancy?
In general, women with CF can have very healthy pregnancies. It's more the health of the mother that we've been concerned about. And the vast majority of women are choosing to continue CFTR modulators during their pregnancy. We are starting up an observational study that will run over the next 4 years, watching those women and also doing testing on newborns and cord blood to learn the safety of CFTR modulators. But so far, the signal is great.
And then one final question. We have 2 questions, but one final question. You want to talk about the cost of drug therapy and how is that being managed in ensuring equitable access to medication?
Well, the list price of CFTR modulators is around $300,000 per year. That is not the cost that most insurance companies pay. And luckily, given that this is a still rare disease, we've had very little difficulty in getting approved for CFTR modulators with our patients. I can't think of any patient that isn't eligible that has access right now. Now that may change over time, but the decrease in hospitalization rate, the improvement in health also has a significant cost saving. And I think we'll know better in the coming years, as we're about 2 years into really highly effective modulation, about kind of what that cost benefit for is on a year-by-year basis.
Okay, well, we are out of time. There's still a few questions. I'm sure Andrew and Phil would be delighted to talk offline with anybody who wants more information. Lots of accolades for a wonderful discussion and presentation in the chat. So thank both of you for an amazing talk and really an amazing success story in medicine. Very exciting.
Thank you very much.
Take care. Bye-bye.
Bye.
Thank you much.